Today we are going to discuss the non-neoplastic conditions of the salivary glands, that is sialadenitis and sialolithiasis. Sialadenitis is the inflammation of the major salivary glands, the parotid gland and the submandibular salivary glands. Acute parotitis, the common cause is mumps virus. It's more common in children since the availability of vaccination against the mumps virus, the incidence is very low. In old time, this mumps virus and the other also viral viruses like Coxsackie virus, Epstein-Barr virus, they cause inflammation of the parotid gland, and this mump virus can be associated at times with arthritis, which leads to an oophorytis, which can lead to infertility, and sometimes also associated with aseptic meningoencephalitis. But this mumps virus infection of the parotid gland is now very uncommon in adults since the availability of vaccination against the mumps virus in childhood. The second cause of the inflammation of the parotid gland is the Paul-Mikulicz disease, in which there is a bilateral enlargement of the parotid gland. There is a dryness of the mouth, which is called xerostomia, and there are also xerophthalmia because there is also dryness of the lacrimal gland produce lacrimal secretions. This Sjogren disease may be primary when the etiology is not known, and this type of Sjogren disease or Sjogren's disease is associated with non-Hodgkin lymphoma. The second type of type 2 Sjogren's disease is associated with autoimmune disease like rheumatoid arthritis, systemic lupus erythematosus, polyarthritis nodosa, and other autoimmune disease, in which again there is a bilateral enlargement of the parotid with dryness of the mouth. In this situation, you have to do the certain test like a rheumatoid factor test and other plasma or electrophoresis to find out the other type of autoimmune disease associated with this Sjogren's disease. It is primarily involving the parotid glands and as well as the lacrimal glands or lacrimal apparatus of the eyeballs. The third type of the infection of the parotid gland, which is recurrent parotitis or the acute suppurative parotitis, is a very serious condition in which there is a bacterial infection of the parotid gland, and this is a retrograde infection from the oral cavity to involve the parotid gland. The underlying cause, which is very important to remember, is dryness of the mouth, dehydration, fluids, electrolytes imbalance with poor oral-dental hygiene, as we will see in patients who have got a acute peritonitis with a long operation, which is typically a Hippocratic phase, and it is a dryness of the mouth which allows the infection to go from the oral cavity through the duct to the parotid glands. If you control the dehydration, cleansing of the mouth with antiseptics, correct the fluids and electrolytes imbalance, majority of this parotitis settle down. The only thing which is important to rule out is the parotid abscess, which can be easily diagnosed if it is not settling down with CT scan. One, if this parotitis is not settling down, the other reason is that there is some sort of a calculus obstruction. This calculus obstruction of the parotid duct is not so common as you find in the silolithiasis in the submandibular gland and its duct system. Majority of the parotid calculi, they are radiolucent. The secretion is serous, the chances, and the calcium level is low in the saliva, so the chances of parotid duct calculi are uncommon as compared to stone in the submandibular salivary gland or its duct. These parotid duct calculi, they are usually multiple, small size, and radiolucent. And the only way to rule out is by doing the CT scan. CT scan has 10 times more sensitivity to pick up the stone as compared to ultrasound or plain X-ray of the oral cavity. So if the stone is the underlying cause, then answer is you have to remove this stone by domia basket, or you can treat the stone through the duct. If the stone is proximally placed in the parenchyma of the parotid gland, or you can say in the small STT ducts of the parotid gland, then answer is you have to do the parotidectomy, which is a major undertaking because it is associated with the certain degree of morbidity in the hands of unexperienced surgeons. The common site of the stone in this submandibular salivary gland or its duct is called Wharton's duct. The commonest presentation of the silolithiasis in the submandibular salivary gland and its ducts is symptomatic. It presents as acute sialadenitis of the submandibular salivary gland, or there is a history of recurrent attacks of sialadenitis. So it is very important to find out what is the cause of this sialadenitis, especially in the submandibular salivary gland. The leading cause of this sialadenitis of the submandibular salivary gland is the calculus obstruction. Remember, it is a very important cause of sialadenitis of the submandibular salivary gland. How it presents? It presents as the patient complained of when he or she chews or mastication of any food, the ipsilateral side which is blocked, the swelling appears as the enlargement of the submandibular salivary gland. It is very painful, it is tender, and you find the flow is obstructed. As a result of obstruction, there is a distension of the gland, and the gland become tender. And if you don't relieve the obstruction, sometimes it can lead to an acute abscess, in which the hectic rise of temperature, fever, and the tender inflamed erythema overlying skin present in the clinical outpatient department. You can simply provoke this swelling by asking the patient to take a sip of orange juice. When this goes, you will find the ipsilateral side which has got a calculus obstruction will show the pain and the swelling in that submandibular area. The diagnosis or clinical impression is confirmed. After the history, it's very classical in case of calculus obstruction of the submandibular gland and its duct. You must open the oral cavity. You look that the submandibular ducts open in the anterior part of the floor of the mouth along the side of the frenulum, and the gland which is obstructed there will be no salivary secretions on that side, and the gland which is not affected, there is a flow of the secretion on the same side. The second thing is that you must do the by digital, bimanual digital examination of the floor of mouth. As you know, the length of the submandibular duct is mainly in the floor of mouth and around about 5 centimeter. You can palpate it by manual digital palpation. You can feel these stones on palpation lying in the floor of the mouth. That is the clinical examination, and then of course you can have gotten the X-ray of the mouth, or second thing is better, just like a roadmap, is the ultrasound that can locate and tell the site of the stone in the submandibular duct or in the submandibular salivary gland. The investigation, which is much more sensitive to pick up the stone in the duct or in the submandibular salivary gland, is the CT scan. It's 5 times more sensitive as compared to ordinary X-ray or the ultrasound. The treatment, as you know, if the stone lies in the distal part of the duct, that is the part of the duct which lies in the floor of the mouth, and you can palpate the stone, you grasp with the forceps the tissue behind the stone so that it can be easily elevated, and then you make an appropriate incision longitudinally in the long axis of the duct and take the stone out. That is what is called as silolithotomy. When the stone lies in the floor of mouth within the submandibular duct, it can be done under local anesthesia, or it may be as an outpatient case. Open the mouth, put local anesthesia in the floor of mouth, gut hold the tissue behind the stone with the forceps and make incision over it and take the stone out. Don't stitch the duct at all, leave it alone, because stitching can lead to stricture, which can cause the same problem as it before. So leave the incision open, and it should be as a good salivary fistula in the floor of mouth. If you don't treat him, that can lead to an acute abscess. In that situation, you have to do a major operation, that you have to incision and drainage of the abscess, first phase, and secondly, you have to excise the submandibular salivary gland along with this duct. If on CT scan you found the stone is not lying in the distal part of the submandibular duct, rather it lies in the neck or within the gland, the option is the surgical excision of the submandibular gland along with its duct containing the stone. That is the treatment when the stone lies in the proximal part of the duct or in the submandibular salivary gland. That is the treatment of silolithasis, which is more common in this submandibular salivary gland and its duct. That finishes about the common non-neoplastic inflammatory condition of the submandibular salivary gland. Now that finishes about the salivary gland disease or disorders, both neoplastic or the benign inflammatory condition of the parotid gland or the major salivary glands. Now we are going to discuss the very important topic, which is very common in clinical scenario, is the carcinoma of the oral, or we can say the oral cavity or oral cancer. The better word is called oral cancer, which includes the cancer of the oral cavity and also the of the oropharynx. Cancer of the head and neck, except the skin, 90% of the cancer they are squamous cell carcinoma. And the squamous cell carcinomas is the commonest cancer of head and neck, barring the skin, which may have got other types of cancer like melanoma or basal cell carcinoma. It is very important in head and neck cancer. You must inspect the scalp face and also the neck. Not only that, you have to open the mouth and look for the oral cavity also, because 99% of cancer of the head and neck, they are squamous cell carcinoma, and they drain into the cervical group of lymph nodes, which are from L1 to L5. Anterior cervical chain is the L1, submental, submandibular, periauricular, postauricular, and occipital, and the deep cervical chain, which runs along the side of the internal jugular vein, covered by the sternomastoid from the mastoid process to the clavicle. They have been divided into three. L2 is upper one third of the sternomastoid, L3 is middle third, L4 is the lower one third, and L5 of course the supraclavicular lymph nodes. These lymph nodes, they drain the lymph from the head and neck mainly, though it also drains the breast and as well as the abdominal viscera through the thoracic duct, which opens at the confluence of the internal jugular vein with the subclavian vein on the left side. The basic principle of cancer, which I must mention for you for undergraduates, is what are the basic principle of treatment of the cancer of the any part of the body. One, treatment of the brain. It is very much important to look for the site. There are certain sites which are hidden and they present with saccine deposits in the lymph nodes of the neck, and the site, sometimes because of the anatomical structure which are not possible to be sacrificed, one has to be very careful. And the certain sites where you can take the aggressive approach with the bidirection. So site is very important. Where is primary site? Second important thing is look for the extent of the spread of the tumor from the primary parent tissues to the surrounding tissues to the adjacent tissues. The second is the lymphatic drainage, that is the lymph nodes which drain the lymph from that particular area. You must palpate them. That is, the cervical group of the lymph nodes must be palpated clinically or tested by radiologically. And in case of head and neck cancer, the distant metastasis is not so common. However, you can find a distant metastasis in the lung or liver. There are three modalities. There are multimodality treatment for cancer of the head and neck or any part of the body. The first modality is surgery. Surgical resection is the best option if it is permissible, and of course if the disease is in early stage. When I say early stage, stage 1 and stage 2. The second option for primary tumor is irradiation. Certain tumors, they are very sensitive to radiotherapy, they can be managed by irradiation. But nothing like the surgical resection if it is permissible. The third thing which can be used as an adjuvant is the chemotherapy slash radiotherapy. Especially when the lesion is advanced, that is T3 or T4. So the treatment of the head and neck cancer depends upon the clinical scenario, that which site is involved and what we have got the best option to treat that area, either with surgery or radiotherapy. In this lecture, I am going to touch the cancer of oral cavity, or you can say the oral cancer. The oral cancer includes the cancer of the oral cavity and the oropharynx. The oral cavity is bounded anteriorly by vermilion border of the lip. Posteriorly is the soft palate, and laterally you will find the palatine tonsil, anterior 2/3 of the tongue, floor of the mouth, mucosa of the buccal cavity or buccal mucosa, and also the alveolar ridge. These are the parts of the oral cavity, that is tongue, anterior 2/3, floor of the mouth, mucosa of the buccal mucosa, alveolar ridge. And in the oral cavity, it also includes the lip, upper lip or a lower lip. Majority of the cancers of the oral cavity, they are squamous cell carcinoma, because the lining is stratified squamous epithelium. What are the pre-cancerous conditions which lead to the cancer of the oral cavity? The first and the foremost important thing is the cigarette smoking. And number 2 is alcohol. If somebody smokes more than 20 cigarettes per day and 6 units of alcohol per day, the incidence of the carcinoma is very common above the age of 45. If nobody smokes or not alcoholic, the incidence of the cancer or the oral cavity common above the age of 60. That is a difference. You should remember that alcohol and smoking in any form, maybe pipes or cigar, whatever you use it, this is cause a desmoplastic change in the lining of the oral cavity. Alcohol and smoking. Third one is the betel nut, chewing of the betel nut, common in India, and they are chronic irritant. They can lead to development of a dysplastic change, chronic irritations. Poor oral dental hygiene or prolonged prosthesis, that is also, you can say, is a carcinogenic. The two important things we should remember, there is a theory about the cancer of the oral cavity is the field cancerization. As the upper aerodigestive tract is exposed to common carcinogens that is alcohol, smoking. So the epithelial lining, the whole epithelial lining of the upper aerodigestive tract may be unstable, or it is more susceptible to undergo a malignant change. This is called field cancerization that establish the fact a patient who has got a cancer of the tongue may have got the cancer of the soft palate or a carcinoma of the cheek because of the unstable lining of the upper aerodigestive tract, because they are common carcinogens to all of the areas. So that is why when you have got a cancer of cheek, it's not essential you don't have a cancer of the tongue. So anybody has got more than one cancer in the oral cavity because it is a field change. So if you take the tissue from the area which is not cancerous, you see under the microscope there is the normal tissue has got a genetic mutation, which may be any time may be susceptible to be the carcinoma. It is called field cancerization. The second theory is the genetic mutations. The cervical cancer is associated with the human papillomavirus. Similarly, the cancer of oral cavity, especially the oropharynx, is 20% may be related to the herpes or human papillomavirus, and that causes mutant, and this virus can cause genetic mutation, silencing, deletion, and the excessive uncontrolled proliferation of the cell because of the genetic material accumulation. So this is only HB, human papillomavirus, is only associated with 20% of the oropharyngeal cancer. First, we are going to discuss the basic principle, the classification of how you classify the tumor. One classification is called TNM classification, T for size of the primary tumor. T1 is the tumor is less than 2 cm, T2 is more than 2, less than 4 cm, T3 is more than 4 centimeters. Similarly, N0, no lymph nodes, N1, the lymph nodes enlarged, size is less than 3 centimeter, N2, the lymph nodes enlarged, the size is more than 3 centimeter and less than 6 centimeter, and this N3 is when the size of the lymph nodes is more than 6 centimeter. And similarly, M0, no metastasis, distant metastasis, and M1 is the distant metastasis. So this is the TNM classification, which is done for both for cancer of the oral cavity and also other parts of the body which are accessible. And the second classification is called clinical classification, is called stage 1. Stage 1, we can convert the TNM classification into these stages. Stage 1 is the T1, N0, M0. Stage 2 is the T2, N0, M0. Stage 3 is the T3, N0, M0. And the stage 3 is also involved the adjacent structures like muscles or bones. And stage 4 is the stage of distant metastasis irrespective of the size of the primary tumor. So these are the classifications of the tumor. We will first discuss the cancer of the tongue. When I say cancer of the tongue, it means the cancer of the interior 2/3 of the tongue, because the base of the tongue, the posterior 1/3, is included in the oropharynx. The majority of the patient in the cancer of the oral tongue, oral cancer, especially the cancer of the tongue, how it presents clinically. One is the ulcer, second is the exophytic growth. Majority of the lesions they are ulcerative, and minority of the lesions they present as a mass or a cauliflower growth. Remember, for life, any ulcer on the tongue, especially at the little border or the tip, does not resolve within 2 weeks' time. It is malignant unless otherwise ruled out. So this is a message for all the undergraduate students. Any ulcer on the tongue which is not resolved, which does not heal in 2 weeks' times, you must consider as a malignant unless otherwise ruled out. This is the lesion which worried when you get the ulcer on the tongue. The second common ulcer is the dental ulcer. It usually happens also along the lateral border of the tongue. There is a sharp edge of the tooth, or there is a dentures are not properly fitted, and there is a rubbing of the denture against the lateral border of the tongue and can produce ulcer. So it is very important. The dental ulcer must be ruled out. The best thing is you should ask the patient to go to the dentist and check up their oral examination regarding the denture or any broken tooth or sharp tooth. So he should do and look into it and sort it out if this is a dental ulcer or not. So if you remove the underlying cause of the dentures or sharp tooth, and you find the ulcer is bound to heal. That is a second common ulcer on the tongue, is the dental ulcer. The third ulcer is called as the aphthous ulcer. They may be solitary or they may be multiple. They are superficial, they are very painful, and they do respond to conservative management with the good oral dental hygiene, and you can take a wash, antiseptic wash, or you can even use the steroids for the healing or to reduce the inflammation of these ulcers. These aphthous ulcers they usually heal up in a couple of weeks' time. And the other ulcer which can present on the tongue on the lateral border is lichen planus. This lichen planus, this can also appear as a whitish patch along the lateral border of the tongue and is not responding to the conservative treatment. The answer is you should consider it for a malignant lesion. When you inspect the oral cavity, there are certain pre-cancerous lesions which worried somebody as a surgeon. One is a leukoplakia. Leukoplakia is a white patch. It is a hyperkeratosis and acanthosis causes in the local irritations, maybe smoking. Smoking is one of the causes of having leukoplakia. When the etiology is not known, it can be caused as a leukoplakia, white patch. 4% of the leukoplakia can undergo transformation into malignancy. So leukoplakia is a precancerous condition. If it does not heal up, or if you think that it is not underlying cause, you can't pick it up, the answer is you must excise the lesion. Leukoplakia is a precancerous in 4% of the cases. The second lesion which is causing the surgeon very apprehensive is the erythroplakia. Erythroplakia is a red patch, depapillated, no papilla, red patch. The incidence of malignancy in the erythroplakia is 90% when it is associated with the leukoplakia, which is called speckled leukoplakia. The incidence of malignancy is 90%. So these two things very important: the leukoplakia, erythroplakia, or especially the speckled leukoplakia when there is a combination of both leukoplakia and erythroplakia. Pigmentation in the oral cavity is unlikely to cause cancer, like malignant melanoma. And the other important thing is that you should never forget the visual inspection of the malignant cancer of the tongue or of the oral cavity is always misleading. Never trust on visual inspection to determine the size of the lesion. You can inspect it, but it is very important with glove on or with or without anesthesia. You must palpate the lesion properly, so that you will be surprised the lesion is much more bigger than what you expect. Your lesion will be upstage when you palpate the lesion with your hands under anesthesia or without anesthesia, and you will downstage the lesion when you only trust on visual examination. That is the other important point. Must palpate the lesion with your hands and fingers. Don't trust on visual inspection. The lesion is much more bigger and is more infiltrative when you palpate the lesion under anesthesia or without anesthesia, especially in the oral cavity. The resection, there are three types. One is the axion, that is called radical section, especially in the oral cavity. You must have got a 1 centimeter all around healthy margin of the lesion. And of course, you also need to check the depth of the tissue, which also takes the underlying tissues also. This is called as radical axion. All around margins, at least 1 centimeter healthy margins, especially in the oral cavity. This is called radical axion. Healthy margin all around. The second axion is called marginal resection. You excise the lesion, but under the microscope you find the tumor cells are found at one border. That is called marginal section, or the tumor cells are found in the very close vicinity of the tumor edge. That is called as the close margin. So close margin, or that is called as the marginal resection, both the chances of recurrence become very much increased. So the marginal resection, you have to revise it. Close resection, you have to revise it if you don't have the facilities of the frozen section and if it is permissible. The third resection is called cytoreduction. That is, you leave the tumor behind apparently because you cannot encompass the big size tumor. So the section are radical section, marginal section, and cytoreduction. To differentiate between the radical section and the marginal section, you must have got the facility of frozen section, especially when you are dealing with the case of the cancer of the oral cavity or of the oropharynx. If the lesion is 2 centimeter or less, can do the segmental resection or wedge resection with primary closure. If the lesion is more than 4 centimeter, which in majority of the patient they come very late, that is a problem in our society. The stage 3 or stage 4, the lesions are bigger in size than what you expect. If the lesion is smaller, you can do surgery alone, it's good enough, but there is a problem with the cancer of the oral cavity. They are biologically, they are very aggressive tumors. So stage 1, I do agree with you, do the local resection and primary closure. But if the cancer of the tongue involving the lesion is more than 4 centimeter, and then answer is partial glossectomy or hemiglossectomy. Majority of the tumors or cancer of the tongue, they are in advanced stage, means stage 3 and stage 4. There are very few cases seen having a stage 1 or stage 2. When the tumor is in stage 3 and 4, surgery alone will not able to give a potential cure to the patient. In that situation, of course, the lesion should be assessed clinically, and second thing is that you must have got a CT scan / MRI. The CT scan will let you more information regarding the bones, because the tumor is involving the bone or soft tissue or muscles. But for soft tissue in vision, MRI is a better option. And then of course, not of the MRI of the CT scan of the oral cavity, to also scan the lymph nodes in the neck. And that is the important investigation. One should do it either before a biopsy when the tumor is very evident, or after the confirmation of the lesion that this lesion is malignant. So how you will take up this case? First thing is that any ulcer which is not healed up in 2 weeks' time must be biopsy. So what sort of biopsy you should take? If the lesion is a bigger one, you can take incision biopsy, taking a healthy tissue along with it, and send immediately to formalin and send to the pathologist. Size and the site must be mentioned on the tissue specimen. If the lesion is small, then you can excise the lesion 1 centimeter margin all around, healthy margin 1 centimeter all around. And that also not only the axiom, but also you look into the tissue depth also, tumor depth. Second, after the biopsy confirm the diagnosis, then answer is second investigation is CT scan. That will let you know the local spread of a local extent of spread of the tumor in the parenchyma or into the adjacent surrounding structures like bone or muscle. It's very important because the lesion which looks like a T1 lesion may become T4 lesion when it has involved the muscle or has invaded the adjacent structure like bone. So CT of the oral cavity and the CT of the neck is very important. Look for the status of the cervical lymph nodes, and plus the primary lesion is heterogeneous. What is the size, what is the extent of spread in the parenchymatous organ or into the adjacent tissues like bone and muscle. The treatment of the carcinoma of the tongue primarily is surgical. Stage 1 resection, radical resection is the answer. If the lesion is T2 and T3, the lesion is bigger, then answer is you have to do the partial or hemiglossectomy. And if the lymph nodes are not clinically or radiologically enlarged, as the tumor of the oral cavity, especially the floor of mouth or tongue, they are very aggressive tumors. One should take up the modified block dissection of the neck on the same side. It has been seen 30% of the cases who underwent prophylactic modified block dissection on the same side revealed micrometastasis. That is the peculiarity which you see in the cancer of the oral cavity or tongue or floor of mouth. So I strongly advise or strongly recommend, as a surgical oncologist of head and neck, any lesion which is 4 centimeter or more than 4 centimeter must be combined with a radical neck dissection, or you can say is the compound resection or composite resection, the removal of the primary and the removal of the secondary in the form of micrometastasis as the presumption. You do combine together. That is about stage 2 or stage 3 plus minus. Regarding the stage 3 lesion, the treatment is always multimodality. You have to do the hemiglossectomy or partial glossectomy combined with modified block dissection of the neck on the same side, because in stage 3 either the lesion is more than 4 centimeter, bigger the primary lesion, higher the chances of cervical metastasis, or the lesion is say 2, the lymph nodes they are positive clinically or radiologically, then answer is that lymph nodes mass has to excise in the form of block dissection. So in modified block dissection, you spare the spinal ancestry now and take off the sternomastoid and internal jugular vein and the lymph node from L1 to L5. If the lymph nodes found enlarged in advanced lesion of the cancer of tongue. Stage 4B, when the tumor is not possible to resect it because it has invaded the vital structure like the in floor of mouth, the carotid vessels or adjacent structure are involved, the lesion is very advanced. In that situation, you have to take the option for chemoradiations. That is neoadjuvant chemotherapy plus irradiation. That will cause downstaging of the tumors. At sometimes is possible to excise the tumor after receiving the neoadjuvant chemotherapy. That is composite resection, removal of the primary lesion, extensive resection plus the block dissection of the neck at the same time. When the question is now how to fill the gap of the soft tissues. There are two options. One is the flaps, and the flaps there are two types. Pedicle flap like pectoralis major flap like the other flaps are also visible. These are known as the available pedicle flaps. They have got their own blood supply and they provide the soft tissue effect from where the primary tumor has excised. This is called flap, which is on the its own pedicle flap, its own blood supply. The second flaps, they are free flaps. When you remove the part of the bone, soft tissue, primary tumor in one go plus a blocked section, then what to do? In that situation, you may have got a free flaps, which is also known as Chinese flap. The harvesting sites is the radius of the forearm, osteomyocutaneous flap, or other harvesting site is the fibula. So you can get a free flaps and you will fix up there by a microvascular technique which anastomoses a vessel, artery, and as well as the vein for the viability of the free flaps. These are known as the Chinese flaps. They take longer time and the surgery may last for 12 hours, maybe 4 to 6 hours section and 4 to 6 hours required for the flea flap implantation by the help of electron microscope or microvascular techniques. Regarding the cancer of the buccal mucosa, you can excise it, and if the defect is bigger, one option is that you can put a partial thickness skin graft either in the floor of mouth or in the buccal mucosa to the cheeks, stitch it, or you just leave this mucosa, no mucosa, you leave this tissue alone. There is no need to put the partial thickness skin graft, you leave alone, let the healing should take place by the granulation tissue. So there is no need of partial thickness skin graft to cover that healing. Because most of the people, they believe that healing takes place by natural process and epithelialization occurs and the mucosa you get is a pink mucosa. This an advanced cancer of the tongue, chemoradiation is the option. That will shrink the tumor. In case of resectable tumor like stage 1, 2 and stage 3A, surgery, irradiation, and if the lymph nodes are found enlarged after the block dissection, it is mandatory to give the chemotherapy, one on the same side minimal, on the controlated side is proper radiotherapy on the opposite half of neck, and of course the primary side after the dissection. So irradiation is very important in case of a larger lesions because the rest of the oral mucosa is also unstable or upper aerodigestion mucosa, and I think irradiation will able to control the theory of field cancerization because the mucosa is unstable and genetically is not normal, even in the normal looking mucosa under the microscope. So irradiation is must if the lesion is in the stage 2 or stage 3, and followed by chemotherapy if the glands are positive for metastatic disease. Nowadays, another new therapy which is called as targeted therapy, cetuximab. This is called monoclonal antibodies, and these target the epidermal growth factor in the tumor cells. This is called targeted therapy, which is a step ahead of the chemotherapy. And this targeted chemotherapy does improve the survival of the patients overall compared with the chemotherapy alone. So that is about the cancer of the tongue, cancer of the buccal mucosa or floor of mouth. You excise them and the lesion is bigger, you have to do the blocked section of neck also. Midline tumor tip, you need a bilateral lymphatic drainage, and if they are large, you have to do the bilateral blocked section. Cancer of the lip, lower lip, the lesion should be excised half a centimeter all around or a 5 millimeter healthy margin all around. After the oxygen of the lip is lost is up to 1/3 of the lip, primary repair can be easily done and give a good cosmetic results. If the lip loss is more than 1/3 of the total lip, then you have to have a lip tissue transfer from the contoured lip. That is called reconstruction. Reconstructive surgery is indicated when the tissue loss is more than 1/3 of the lip. This tumor is not so aggressive. Results are excellent. 5-year survival rate is 95% if the adequate treatment is being carried out. So, we discussed the cancer of the tongue, buccal mucosa, and the cancer of the lip. Option of the defect is primary closure if the lesion is small, and if the defect is large, then there are two ways. Either you place a partial thickness skin graft in the floor of mouth, or sometimes you have to bring the flaps. The flaps, there are two types. One is the pedicle flap, like a pectoralis major or flap, it is blood supply, or you can have a free flaps which contains the muscle, soft tissue, skin, and a piece of bone sometimes required. This is called osteomyocutaneous flap, a Chinese flap, with microvascular techniques. You anastomose the small vessel of the flap with the surrounding artery, and also one vein you have to anastomose. It may be common facial vein or with the other facial artery. Multimodality treatment is usually taken into consideration in cancer of the oral cavity. As I have told you, because there are higher chances of second cancer in the oral cavity, the basic concept is field cancerization. You excise the one tumor, and after 6 months or 1 year, you can develop other primary second tumor, because the carcinogens, they are common for both upper aerodigestive tract. The complication of the surgery and as well as the irradiation will be discussed later on. And now we will discuss the cancer of the oropharynx. The cancer of the oropharynx includes the base of the tongue, the tonsils, the soft palate, and as well as the posterolateral pharyngeal wall. The carcinoma of the oropharynx may include the base of the tongue or tonsils or the posterior pharyngeal wall. They usually diagnosed at a very late stage because they do not cause any symptoms. When the symptoms develop like dysphonia, dysphagia, difficulty in breathing, the lesion is very much enlarged. So majority of the patients, they come at a stage of stage 3 or 4. In that situation, if you look at the neck, the lymph nodes found enlarged. Sometimes you find the primary lesion is small and there is a bilateral cervical metastasis. And these lymph nodes suggest a metastatic deposit while the primary is either hidden or small. So it is very important to inspect the oral cavity, and then the advice must be taken from the ENT surgeons that you should look for the nasopharynx, periform fossa, area epiglottic fold, base of the tongue, soft palate, lateral and posterior wall of the pharynx, and the tonsils. Because it is very important to pick up the primary first. The basic principle of surgery is, in cancer surgery, treat the primary first and then treat the secondary deposits either at the same time or afterwards. Never treat the primary first and either leave alone the primary or you treat the primary afterwards. That is wrong principle. Treatment of primary first and the treatment of secondary second. Or treatment of primary and the secondary can be taken into consideration simultaneously at one time. So, in this situation of the carcinoma of the oropharynx, which is very advanced in stage 3, stage 4, one should have to take the biopsy for confirmation. It is possible not to resect the base of tongue. When you resect the base of tongue, the blood supply of the proximal to third tongue is also go away. So there is no other option to do the total glossectomy, and that has got a very high morbidity because it can cause difficulty in dysphagia, difficulty in swallowing is there, and there are difficulty in phonation. And if you, at the same time, sometimes there may be also difficulty in deglutition because there will be involvement of the various nerves also, and that can result in severe morbidity of the patient, and the patient may not able to swallow, or water can come out through the nose because the glossopharyngeal nerve or the other vagus nerve may be at risk of damaging when you perform the total glossectomy. So that is why this operation is not indicated. So treatment will be the irradiation of the primary tumor and irradiation of the secondary deposits in the lymph nodes of neck. The radiation alone can able to look after both, and you take the biopsy, and biopsy is confirmed, then you can also use with chemotherapy also if these lymph nodes are found enlarged and they are involved by cancer. So metastatic deposits and the primary cancer in oropharynx mainly dealt by chemoradiations. That will shrink the tumor, and there is potential of hope for cure, but regular follow-up is required. They are very notorious tumor because by the time they are diagnosed, they are too late, and the surgical section is not feasible, not permissible, not wanted because of lot of severe morbidity, and at times also mortality also. So that tells you the short story is the cancer of the oral cavity is a very aggressive tumor. In majority of the patients they come very late. Biopsy must be taken any ulcer anywhere in the oral cavity. If it does not resolve or heal in 2 weeks times, and usually in these situations as an advanced cancer stage 3, 4 or stage 2 plus stage 3 plus minus, you have to take the consideration of multimodality treatment, that is surgery, irradiation, and if the lymph nodes found positive, answer is chemotherapy, and certain tumors they do respond to targeted chemotherapy, cetuximab, like monoclonal antibodies which target the particular tumor cells. This targeted chemotherapy can be used in head and neck and also in breast cancer, like HER2 receptor positive use Herceptin. Similarly, you have cetuximab, that is a monoclonal antibodies which target the tumor cells, especially for their epidermal growth factors. Head and neck cancer should have a regular follow-up. There are high chances of recurrence. The 5-year survival rate is less than 50% overall, and one should have to follow up till life. That finished about the cancer of the oral cavity. Thank you very much.